Thank you very much. First of all, I would like to thank the organization of the Congress for this invitation.
No questions? No questions for the gentleman?
At the end of the...
Oh, okay.
Sorry. I think it was a very good initiative, and I hopefully we can have many more like this. My topic is supraventricular tachycardias in women. I am Dr. Marta, EP consultant in Rashid Hospital. These are the most prevalent tachycardias by gender. In women, we have more inappropriate sinus tachycardia, more postural orthostatic tachycardia syndrome, POTS, more AV and RTs, more idiopathic right ventricular tachycardias. Our QT is longer than men, and when we have long QT syndrome, we have more ventricular arrhythmic events also. And the more prevalent arrhythmias in men are those related to accessory pathways. They have more atrial fibrillation, more ventricular tachycardias in general due to ischemic heart disease, Brugada syndrome, AV block, and carotid sinus syndrome. Why these differences? I think this has been said all over the Congress. We have different sex chromosomes protecting us from atherogenesis. We have different hormones. The estrogens protect us from oxidative stress, from ischemia, from cardiac remodeling. And our autonomic tone is different. We have an increased vagal tone and a decreased sympathetic tone that makes us have lower blood pressure and a tendency to vasodilation. Going back to the topic, the most prevalent SVTs in women are inappropriate sinus tachycardia, which is defined by more than 100 beats per minute at resting, atrioventricular nodal reentrant tachycardia, which is a micro reentry close to the AV node, and postural orthostatic tachycardia syndrome, POTS, which is defined as an increase of more than 30 beats per minute in the first 10 minutes of standing up with no drop of blood pressure. Otherwise, it would be orthostatic hypotension. Because we have limited time, and because the first ones are more prevalent, I'm going to focus my talk on IST and AV and RT. Inappropriate sinus tachycardia is defined by persistent or can be also paroxysmal, but otherwise unexplained sinus tachycardia with resting heart rate more than 100 beats per minute associated with distressing symptoms. It is 4 times more prevalent in women than in men. It affects females between 15 and 45-year-old, and sometimes is underdiagnosed or misdiagnosed and is labeled as anxiety or depression, which delays the diagnosis. The diagnosis of IST is a diagnosis of exclusion, so you have to make a good differential diagnosis. This is very important. You have to rule out all these secondary potential causes. Just a good history, a lab test, and an echocardiogram will rule out most of these secondary causes. What is the clinical presentation? The clinical presentation can be very variable, but of course, palpitations is the main symptom and is the symptom that leads to the diagnosis. But it can go also with fatigue, with shortness of breath, with chest pain, dizziness, intolerance to exercise, anxiety, panic attacks, headache, etc. The symptoms, and this is very important, like in sick sinus syndrome, the symptoms must be correlated to the heart rate. And very frequently, the symptoms lead to physical debilitation. The patient does some physical activity, feels the tachycardia, feels the palpitations, and decreases the physical activity. So this creates a vicious cycle, and that's why encouraging the patient to do some sport is very important. The symptoms can be persistent or in paroxysmal episodes. IST can be apparent after catheter ablation of other arrhythmias, like AF or AVNRT, either because the parasympathetic ganglia surrounding the heart are also ablated. This is very frequent, quite frequent in AF ablation because the clusters of the ganglia are surrounding the pulmonary veins, or can be because of the coexistence of both types of tachycardia. One was masking the other, and by treating one tachycardia, the other becomes apparent. And it can be overlapped with other syndromes, like vasovagal syncope or POTS. This is an example of a diagnostic approach. First of all, you have to rule out any secondary cause, the differential diagnosis. It's important to rule out POTS, do an orthostatic test, and measure the vital signs to rule out POTS because they don't have the same treatment. You're not going to give ivabradine, for example, for a POTS. 3, long-term monitoring is very important. An event monitor or an implantable loop recorder to correlate the tachycardia with symptoms, as I said, is very important. And also to assess the heart rate variability, which is decreased in IST. An echocardiogram is essential to rule out any structural heart disease. Exercise tests could be optional to demonstrate exaggerated chronotropic response and maximum heart rate reached at early stage, demonstrating this physical debilitation. And sometimes an EP study is necessary if you think that an SVT can be underlying. What about the treatment? First of all, the visits are very long. You have to talk a lot with the patient and clarify all the expectations. They have a lot of questions, a lot of doubts, and patient reassurance is very, very important. Second, lifestyle modification. Physical activity is essential. You have to encourage the patient to do physical activity. Seems that yoga could be one of the best options because the patient earns strength, but without this feeling of palpitations. The tachycardia is not that much during the yoga. But any sport will do. If it's a sport in a group, it's better because socializing can improve symptoms. Of course, you have to avoid any stimulants like tobacco, alcohol, drugs, coffee, tea, and avoid anything that can lower the blood pressure and can increase the heart rate secondarily. If you need a drug, of course, the first choice is ivabradine because it's the inhibitor of the funny channels. The funny channels are those located mainly in the sinus node and are responsible of the pacemaker of the heart. It's superior, ivabradine is superior to beta blockers and calcium antagonists in decreasing the heart rate and have better tolerance and improves tolerance to exercise too. Second choice would be beta blockers and calcium channel blockers, but as you may know, they are not always tolerated due to fatigue and low blood pressure sometimes. And finally, anxiolytics and antidepressants only and only if you have a diagnosis of a psychiatric intercurrent disease. Ablation is the last choice. And why? Because the sinus node is a diffuse structure. And it has many exit sites. It's not like the AV node that only has one exit through the His, and that's all. Normally, you start burning by the earliest side, the upper side of the sinus node, and the activation finds the way to go, finds another door, and you have to burn a little bit more and a little bit more. And of course, we don't want to block the sinus node because these are young females and we don't want to end up with a pacemaker. The target is sinus node modulation. And this is not so easy to reach, at least in one session. Normally, you need one session and maybe more than 2 sessions to get a good result. There's another way to do the ablation. This is the hybrid ablation. It's done through the epicardial space and endocardially also. Endocardially with your classical catheter. Epicardially, as you can see, they use this fancy bipolar clamps. And of course, you need thoracoscopy. And you put these clamps in the superior vena cava ostium, in the inferior vena cava ostium, and all along the lateral side of the right atrium, all along the crista terminalis. This approach has a much higher successful rate, to tell you the truth. Normally, in one procedure, you reach your target and has significantly less recurrences. The problem is that, as you can see, is more invasive and has a very high incidence of acute pericarditis. And of course, it has to be done in high specialized centers. So as a summary for the treatment of inappropriate sinus tachycardia, first of all, exercise and lifestyle modification. If you need a drug, ivabradine is the first choice. If it doesn't work, you will combine ivabradine with beta blockers or calcium antagonists, and catheter ablation last choice, when only for very, very symptomatic patients. And I'm going to talk about atrioventricular reentrant tachycardia. This is the most common SVT worldwide, twofold women compared to men. And why is more prevalent in women? Because of the, again, our sex hormones and differences in the autonomic tone. This is the classical scheme of an AV-NRT. This is a reentrant tachycardia. For any reentry, we need 2 pathways with 2 different conduction times and 2 different refractory periods. First, you have a sinus beat when the atria reaches. It's a pity that I don't have a laser. Anyway, when the activation reaches the AV node, it goes down through both pathways, the slow pathway and the fast pathway, and reaches the His. When the slow pathway reaches the lower side of the AV node, the tissue is already activated and it's refractory, so it cannot go up. What happens if we introduce a premature atrial complex? When there is an extra stimulus, the extra stimulus finds the fast pathway refractory from the previous sinus beat. So it only goes down through the slow pathway. And when the conduction reaches the lower side, the fast pathway is not refractory anymore, so it can go up through the fast pathway. And when it reaches the upper side, the slow pathway is again active, is not refractory anymore, so it closes the loop and the tachycardia starts. Why this happens more in women? Because we have a higher incidence of atrial His jumps, we have higher incidence of slow pathways, and we have a shorter refractory period of the slow pathway. It doesn't go. Okay. Yeah, how the hormones affect the higher prevalence of AV-NRT. Estradiol protects us from AV-NRT, and progesterone induces more AV-NRT, because progesterone lowers the intranodal conduction and lowers the refractory period of the AV node. This explains more episodes and longer episodes at onset of menses or during premenstrual phase. And this explains also a second peak of incidence during the 6th decade, during the menopause, and a more frequent and longer episodes during pregnancy, during high progesterone levels. How the increased vagal tone increases the episodes of AV and RT is not so clear. And this is a study done in 2019. Needless to say that the treatment, the definitive treatment of AV and RT is ablation. It is the only curative option. And in this study, which was published recently, they tried to find differences between women and men in the therapeutical approach. And they found that prior to ablation, women had more visits to the emergency room, more than men, significantly more. They tried more medications before ablation. The time from initial symptoms to the diagnosis was longer for women. The time from diagnosis to ablation was very significantly higher in women, and also the time from symptoms to ablation, the initial symptoms to ablation. And they tried to find why, the reason for these differences. And they found that women have a preference for medications, maybe, over ablation due to potential complications. And women have more caregiver roles, 11% for women and 0 for men, as you can see. Also can be that women have a different way of communicating symptoms, can be differences in how physician interprets women's symptoms. Females may be more risk aversive, as I said, and could be also physicians' gender bias in referring females for ablation due to concerns about radiation exposure, since AV and RT is occurring more often in childbearing age. And in this regard, I'm going to show you how I do AV and RT ablation in our cath lab in Rashid Hospital. As you can see, I don't wear any lead. Any of my staff is wearing any lead. So there is no radiation at all, and we protect our backs. This was a case of a young female with 10 years of these palpitations, these episodes of AV and RT, go into the emergency room every time, and finally, after 10 years, she decided to do something. All our femoral punctures are done echo-guided, so we minimize the risk of any vascular complication. And after that, what I do is go in with the catheter to the right atrium, and I do an anatomical map of the right atrium. It's very important to map very carefully the His. The His are the yellow balls. Now I go to the coronary sinus, as you can see, in the right side. And then I do all the anatomical map of the rest of the right atrium. Once I have the anatomy and all my catheters in place, I do the diagnostic part. We induce the tachycardia, we do the pacing maneuvers to confirm that these are the pacing maneuvers to confirm that this is an AV and RT. And finally, once I have the confirmation of the diagnosis and the anatomy, I burn. This is a drawing I did for you of the Cox triangle. The vertex of the Cox triangle is the His, the yellow balls. The posterior wall of the triangle is the coronary sinus ostium, which is the blue ball. This connects by the tendon of Todaro and the tricuspid valve below. Between the tricuspid valve and CS os, you can find the slow pathway. The red balls are the ablation points, and in this case, with just one ablation, one shot, the tachycardia could not be inducible anymore, and the patient was cured. Sorry, it's just one slide, I think. But I'm stuck with the thank you message. Just one slide. So as a conclusion for the AVNRT, ablation for AVNRT should always be on the table since the very beginning, since the first symptom, as it is the only curative treatment. The ablation of AVNRT is a very safe procedure with close to zero complications. In our center, it is zero. And radiation should not be a concern anymore, neither for patients or for doctors, as it is possible to do it without radiation. And thank you very much.